All right. Hello. My name is Erik Schabert, DO, and I am here today to talk a little bit about male hypogonadism. I think this is going to be information that a lot of you out there are going to find useful. So, male hypogonadism is a little more commonly known as low testosterone or low T in men. We really start to see the prevalence of it spike in men over age 45. A recent study in the International Journal of Internal Medicine estimated the prevalence of male hypogonadism at a little bit over 38.7%. So this means there most likely are a lot of you out there that are going to be watching this video who either have or know someone with low T. The odds of testosterone being low increase with certain conditions. The most common of these are diabetes and obesity, and somebody who is both obese and diabetic has well over a 50% chance of having low testosterone. I've even heard a few researchers say that there is no better single indicator of metabolic health in a man than their testosterone level. So let me talk a little bit about what defines low T. The normal level for testosterone on most commercial lab tests is between about 250 and 1100 nanograms per milliliter for total testosterone. However, we say a man is hypogonad or has low testosterone if they have a level under 300 nanograms per deciliter with symptoms consistent with low T. So those symptoms include poor libido, erectile dysfunction, fatigue, generalized weakness, poor exercise tolerance, generalized musculoskeletal pain, poor sleep, loss of body hair, loss of lean body mass, and possibly elevated fracture risk as well. And again, we usually start to see hypogonadism in men as they age past 45. The incidence does tend to go up with age as well. And to give you an idea of what an optimal level for a young man is, the average total testosterone level in young men is 621 nanograms per milliliter. We also need to talk a little bit about free testosterone because testosterone is a steroid hormone, meaning it is fat soluble and not water soluble, so it will not dissolve in blood readily. Because of that, the majority of circulating testosterone in any man is bound to something called sex hormone binding globulin. If we have too much of that, we can have a low testosterone, free testosterone level, despite having a normal total testosterone, meaning that a man can be hypogonad with a normal total testosterone level, and it's actually possible for a man to have slightly low total testosterone and still be essentially normal because their free testosterone is in the normal range. The lower limit for free testosterone is 50 nanograms per deciliter. Okay, so next I want to talk a little bit about some of the additional risks associated with low testosterone. Obviously, we talked about the effects on libido and mood and energy levels and sleep, which are very important. There additionally may be an increased risk of cardiovascular disease. The data on that is not conclusive at this point, and as a result, it's something we'll have to monitor. I do suspect that with better studies that we may well be able to prove that not only does cardiovascular risk increase with low T, but that replacing testosterone actually eliminates that risk. All right, so there are a lot of forms of testosterone replacement available for men who do have low T. When I began training, really you were only talking about injectable testosterone, oral testosterone, and testosterone patches. We don't even use the patches anymore. And now there are multiple additional options. We have a topical gel that's been on the market for more than 20 years now and is widely used along with a different form of oral testosterone than was available when I started training. It's a newer delivery system, much better than the original. And we're still using testosterone injections, and now there are even implantable pellets. They were around when I started training, but they weren't used very much in the US, and they're becoming much more common now. There are advantages and disadvantages to each of those treatment approaches, including that with injections and with the pellets, each of those you're getting kind of a bunch of testosterone at once, and the level is decaying a little bit over time. So very frequently, men, as they get closer to the time when they would either have pellets replaced or take another injection, will start to feel some of those low T symptoms again. This can be mitigated by closing the interval in which either the pellets are put in or injections are done. When I started training, the injection regimens were either once a month or once every 2 weeks, and we were using relatively high doses. Now we will take that same dose and sometimes spread it out and do the injections, as in some cases even daily, but certainly twice a week is quite common. Weekly is a little rare, daily, is a little bit rare, but we do see that done still. And if a guy can tolerate having injections that frequently, it does bring us a little bit closer to the way that body does testosterone. Oral testosterone has a relatively short half-life, meaning that it only stays in the system maybe 6 to 8 hours after dosing. And so we will tend to dose it first thing in the morning and then maybe at lunch, ideally to again have a testosterone cycle that's a little bit closer to what our body does naturally. The advantages to more frequent dosing, one of the biggest is that it reduces the incidence of the more serious side effects from testosterone supplementation. The primary ones we worry about are additional clotting risk and cardiovascular adverse events related to that increased clotting risk. Most of that clot risk occurs because big spikes in testosterone can cause a condition called polycythemia. What polycythemia literally means is too many cells. And we see big bumps in the amount of red blood cells and platelets that we have with these spikes in testosterone. And this can absolutely lead to increased incidence of clots and adverse cardiovascular events. Merely spreading out the dosing reduces the risk of that. Another adverse thing that can occur with testosterone supplementation are elevated levels of estrogen. This can lead to more labile mood, particularly being prone to episodes of sudden crying and sadness. And even you can get a condition called gynecomastia, which is the development of female-type breast tissue in men. Now, once again, reducing those spikes in testosterone largely eliminates these problems. If we, for whatever reason, need to dose in such a way that we are getting some spikes out of that normal testosterone range, and men are developing these kinds of side effects, we can treat with something called an aromatase inhibitor that prevents the conversion of testosterone to estrogen, and that can eliminate some of those symptoms. We have to be careful with aromatase blockades, though, because doing that and really pushing estrogen levels down also can have adverse effects. Estrogen is necessary in men for good bone health, and it's also actually necessary for feeling good as a male and having normal libido. So it has to be a balance, and if we do use aromatase inhibitors, we have to make sure we're not pushing estrogen too low. All right. Also, one of the concerns with testosterone supplementation is that if we just give testosterone, we are going to push sperm counts basically down to zero. So if we're treating a man who wants to maintain his fertility, we have to use other options. And we do have drugs that we can give that act in the brain to tell the testes to make additional testosterone. And these do frequently work. They're not as potent as giving testosterone alone, which is why they're not frontline, but they can eliminate a lot of the potential side effects and definitely can help a man maintain fertility through testosterone supplementation. Targets for treatment are a little bit controversial. We always try and replace to a total testosterone level above 400 nanograms per milliliter, and individual physicians will have their own targets for free testosterone with regards to supplementation. We do not like to try and push the testosterone level above 1,000 because if you get above 1,100, we do start to see some of those adverse cardiovascular effects. There's also an issue with causing prostatic enlargement when we replace to higher levels. And so men who have known enlarged prostates with lower urinary symptoms, that is something that we need to monitor when we're doing supplementation as well. I said it previously, but I want to mention again, the average level in a young healthy male is 621 nanograms per deciliter or thereabouts. And so that can frequently be something of a target level, although what is optimal in any individual man is going to vary person to person. So we sometimes have to trial and error it a little bit and see where things can dial in and you really feel good. There was a point not too long ago when we were very much concerned about adverse cardiovascular risk with testosterone supplementation, and we were also very much concerned with the risk of prostate cancer going up with testosterone supplements. As a result, the National Institutes of Health paid for and initiated a study called the TRAVERSE study. This study showed definitively that there was no increased cardiovascular risk with physiologic levels of supplementation. That is, supplementation to levels that are inside the normal testosterone range. The TRAVERSE study was really done on men who had elevated cardiovascular risk already. So with there being no relative increased risk in that population, we are confident that men in general just will not have additional heart attacks and strokes because they're on testosterone supplementation. And that is very important. This study also caused the medical profession to pull back a little bit on not using testosterone supplements in men with known prostate cancer. As of today, the only contraindication for testosterone supplementation with regards to prostate cancer is if a man has a known testosterone sensitive cancer that we are treating with androgen blockade. If we're blocking the action of testosterone in the prostate, we are not going to be giving testosterone, even if a man is low, and he's going to be low on an androgen blockade. It just is. Now, once treatment with androgen blockade is completed, or if an individual has prostate cancer, but androgen blockade is not indicated, we definitely can still supplement testosterone. Just we need to be very careful to keep it in the physiologic range. Well, that covers just about everything I wanted to talk about with regards to a testosterone replacement in hypogonadism. If you have additional questions, please leave them in the comments section. I will be happy to respond. If they require a complex enough answer, I will even make a video. Please also like, subscribe, and share this video if you found it helpful. Please do remember, this does not constitute medical advice. The intent of this channel is to give you information that you can discuss with your doctor to make appropriate treatment decisions. Thank you so much for tuning in, and I will see you next time.